All right. Good morning, everyone. Morning. Okay, so today we're going to cover the comprehensive echo assessment of the TAVI valve. Um, when I present echo rounds, I like to present something that is a little bit more kind of tailored and unique. And it's something that we deal with regularly in the echo lab on a day-to-day basis. So these are the objectives. So first, we're going to review the echocardiographic assessment of the post-TAVI valve, particularly identifying and assessing severity of stenosis and regurgitation. And along the way, we'll review some interesting kind of illustrative cases. It's all about the scanning and the interpretation. So I think all of us know that TAVR, transcatheter aortic valve implantation or replacement, has seen exponential growth since it was initially introduced in the mid to late 2000s. This graph is from the STS ACC TVT registry from 2021, so it's a little bit out of date. But you can see, I'm pointing here. So in blue here is isolated SAVRs or surgical aortic valve replacements. All SAVRs are at the top, which is aortic valve replacement plus other valve procedure plus or minus bypass surgery. And in the orange, this exponential growth, this rapidly ascending curve is TAVR or transcatheter aortic valve implantation. So in this registry, which is mostly North American, the number of TAVRs exceeded the number of isolated SAVRs between 2015 and 2016. And then later on in that decade, it exceeded total SAVRs. So we did our first case at St. Mike's in 2009. And that year we did 19 TAVI cases. And between 2009 and 2014, we did a total of 207 cases. That was the early days of TAVI.
Wow.
Um, and last year, fiscal 25-26, we did 372 transcatheter aortic valve implantations. And the sonographers know they'll see TAVIs usually Tuesdays or Wednesdays. We have our TAVIs usually on Tuesdays. So and they do come back for follow-up after the initial TAVI. So we see them quite regularly in the echo lab.
Do you know how many SAVRs we did in that time?
I do not know. Yeah, it's a good point, but I suspect it's less. Yeah, and it kind of fits with what we know from these registries. So back in those days, there were two valves that were available. The balloon expandable sapien valve on the left and the self-expanding core valve on the right. And we ended up being mostly a sapien site. So and back in those days, it used to be TE guided. I don't know if people will actually remember that or knew that or recall that. And so and at that time, I was the one who was I was director of the Echo Lab at the time, and so I was involved in doing this. And I can tell it's pretty challenging to guide it with TEs. So these are floor images at the top, corresponding still frame T images on the bottom. If you can see the positioning of the TAVI valve that's not been inflated. They've done a root angiogram. You can see the cusps outlined here. So they're trying to align it to the annulus and trying to correspondingly align it to the T image. Here it's inflated, and here is deflated. Similarly here, inflated and deflated here, post inflation and post implantation. So here's a you don't see this anymore because we don't do it T guided. So this is rapid pacing to decrease stroke volume. The fluid inflates, and then it deflates, and then you turn off the pacing. So yeah. So I think this is the first case actually. I think it might have been one of my patients.
And it's a GE.
Yes, back in those days, the G was the go-to system for T imaging in the lab. So I think she was in her mid to late 90s, if I recall correctly. So what this is our first. This is 2009. So fast forward to current state, although this is a couple of years old. This is published in 2024. This is the current slate, at least in 2024. There may be a few more new valves, but this is what we have on the table now. So it's quite a lot more. So there's the self-expanding valves. The core valve has now moved on to the later generations, Evolut R, Pro, etc. Sapien has moved on, the balloon expandable valves to the Sapien 3 Ultra, Ultra Resilia. We've seen these in our lab. Um, uh, we still have Evolut on the table for us. We used to use more portico. I'm not sure if we're still using any portico, but we're using more Navitor valves as well. And these are also self-expanding. The balloon expandable valves tend to sit close to the annulus, the native annulus of the aortic valve, while the self-expanding valves tend to be a little bit supraannular. If you pay close attention to TAVI valves, they're a little bit above the annulus. And actually helps because they generally have a slightly higher effective orifice area, especially when you're looking at the small LVOT or small annuli. And there used to be these mechanical expandable valves expanded by a motor, but they came off the market a number of years ago because of complications, etc. So the major questions once the patient comes to the lab and they've had a TAVI in the past. So is the heart valve well positioned? Is it functioning normally? Is there any regurgitation? Is it intravalvular or transvalvular, or is it paravalvular? Sometimes that's sometimes it's not easy. And then on top of that, you have to determine what the severity of the regurgitation is. Is it mild, moderate, severe, etc. Has the TAVI produced the expected ventricular and hemodynamic response? Is the valvular aortic stenosis relieved? And is there any early or late complications? So these are all things that the sonographer and the physicians have to think about when the patient comes to the lab, they're scanned, and you have to interpret. So these are the things that we do on a regular basis. We want to look at the structure and position, something we kind of take for granted sometimes. We assume we assume it's in the right position, and it is 99% of the time, but sometimes it's not, and you have to be aware of that. So is the position of the frame relative to the annulus and the LVOT, knowing that some valves are at the annulus, some valves are supraannular. Does it look circular? Is there a good expansion of the frame? Is it a good apposition to the native annulus? Can you see the leaflets? Sometimes it's difficult to see the leaflets because of shadowing from the struts or the stents of the valve. Can you see the number? Are the leaflets thick? Are they moving? Are they coapting well? Is there any flail? Is there any masses on the leaflets or the cusps? Is there a restriction to cusp motion, calcification? Is there any tears or prolapse? Is there any abnormal motion, rocking, migration, embolization? What's the relationship between the ventricular frame of the valve and the anterior leaflet of the mitral valve? Is it obstructing the mitral valve opening, for example, if it's sitting too far in the LVOT? And what about calcification and creating any problems with regards to that to the valve function? So this is Evolut R. So this is the self-expanding supraannular, so deep shot. You can actually see the cusp motion pretty well here, actually. And you can see it's sitting fairly well above the annulus. It's almost in the middle of the aortic root. Here's a zoom view here. You can see. You can see the struts coming into the LVOT. Looks fairly well positioned, and it's stable. It's not moving. And the core valve, the supraannular, they tend to flare out into the root, so they're fairly bulky. And you can see it sometimes with a mesh in the root, while the sapien is a little bit more compact, and you don't see it extend as much. So this is apical 5-chamber view, apical 3-chamber view. So really nice, clean imaging. Once again, you can see the cusps here, and the annulus is probably somewhere over here. So and here, cusps here, and the annulus of the valve is somewhere over here. So really nice positioning.
So it's the leaflets that are supravalvular, not the struts.
Well, the struts or the stents of the valve really they extend from below the annulus to above the annulus, of course. And then with the core valve, it really extends. You saw the image I showed before. It's a bit of almost like a skirt coming out into the root. So in terms of aortic regurgitation assessment and the protocol behind it, and these are the sonographers, they do this on a daily basis. So you want to look at the parasternal long axis and short axis and the apical views. Ideally, do some sweeps, and we're good at sweeping. Most sonographers love their sweeps through the anterior and posterior annular regions, both on the long axis and the short axis. And for the short axis sweeps, it's important to go from slightly above the valve through the annulus to below the valve. And looking for paravalvular regurgitation, you really want to image below the annulus because you tend to see it more at the LVOT level, at the edges of the stent in the LVOT. I know the short axis image, if you do your standard short axis imaging of the aortic valve looking for the cusps, you may not be at a plane to look at paravalvular regurgitation. So, we encourage our sonographers to do the sweeps, identify where that regurgitation is, and then you go back and you focus on that one particular area, and you really have to show the readers, right? Because if not, the readers are going fast sometimes, and sometimes they go too fast, they might miss it on the sweep. And sometimes the sweep is like 10 seconds. So I'm not sure, the whole 10 seconds, it's a little bit more challenging sometimes. Exactly. You had to be patient. Okay. Then you got to go multiple apical long axis, off axis views. The color Doppler appropriate Nyquist limit, obviously 50, 60 centimeters per second. And then looking at the hemodynamic response, you want to be able to do continuous wave Doppler, looking at pressure halftime, pulse wave Doppler in the descending thoracic and abdominal aorta. Pretty standard things that we do for any kind of aortic regurgitation. And when we think about the regurgitation, especially if it's paravalvular, you want to look at the location. And then we tend to report it based on a clock face. So a short axis view is at 12 o'clock, which is anterior, is at 6 o'clock, which is posterior, is it lateral or medial, etc. So lateral kind of at 3 o'clock, 9 o'clock is kind of medial, kind of more towards the right heart. Okay, so let's take a look at, I always include lots of, an echo rounds is not echo rounds, unless 50% of the slides are echo images. Actually, more like 70%. So here's a parasternal long axis without color and with color here. So what do we see? So there's some regurgitation. The valve is well seated. What kind of valve do you think it is? Based on what I told you before. Pardon me? Yeah, why? There's a lot of stuff at this above here. Yeah, exactly. Yeah. Yeah. This is a navitor. This is one of the self-expanding valves. And there's regurgitation here. Is it intravalvular or is it paravalvular? Pardon me?
Both.
Is it both? Okay, that's covering the bases, that's sure.
In exam setting, more images.
Yeah. So I can tell you when I look at TAVI valves and I see regurgitation, my automatic instinct is that it's paravalvular. Just you close your eyes and you see and they tell you there's regurgitation. The majority of the time it's going to be paravalvular. So that's the starting point. And then you have to prove it to me, and you have to prove to me it's not. If you're calling it valve, you have to prove it to me that it's not paravalvular, because my default is that it's probably paravalvular. Just pure bets, right? So. Okay, so here's the sweep. So, and this is you can tell it's going from kind of RV outflow into RV inflow. So it's going kind of more lateral to medial. So here's it's sweeping through. There's a regurgitation. So location is a bit anterior, right? So now these are just two different planes. So sonographer's gone back and gotten 2 beat cardiac cycles here and a little bit of angulation here. And then you're thinking about severity, right? So here, just based on this one view, obviously you have to use multiple views, etc. This looks mild. Okay, here's short axis. Now, unfortunately, this is the only short axis we got. So do you see any paravalvular regurgitation? Do you see any regurgitation? No, we're not in the right location to find
yet.
No, actually, we didn't get it. So not yet on this patient, and not ever on this patient. So yeah. So here you're scanning at the cusp plane, and unfortunately, you don't see any regurgitation. So it's going to be lower. You got to scan into the LVOT. So yeah.
Yeah, that's when the video tape.
Sorry, my apologies. For this one, we did get it. So this is the sweep. So I was thinking about another case. It's okay. You'll see later.
Yeah, we used to do all that on
Yeah.
videotapes.
So here's the sweep. Yeah. So there's the paravalvular regurgitation. It's a little bit anterolateral, I guess. It's kind of like a 2 o'clock, 1 o'clock, 2 o'clock.
2 o'clock.
Yeah,
Okay.
yeah,
Yeah.
yeah. And what's this? What's this little red flow? This little red, this focus here is just scan through. What's that? Is that a fistula? What is that? Is that a fistula from the root into the RVOT? No. What is it?
Oh, CI.
It's pulmonic regurgitation. It just happens to be at the location of the paravalvular regurgitation. It's kind of a bit of a decot. Phoebe, I think you scanned this one.
There's no washing jet because it's not a mechanical valve.
Yeah, I think Phoebe scanned this one. So I think you actually did explain across this because you weren't sure whether there was a fistula or not. So okay, so yes, so that's right. This is one of the good ones. So Phoebe's gone back to the kind of so saw it on the sweep, and then you show it with a 2-beat cycle, color compare, which is useful if you want to see where the cusps are, and you can see the regurgitation here. Now you wonder if it's a little bit more than
Wow.
what you like. Yeah, because of so the circumference, I'll talk about it. The circumference index is one of the factors that you look at the severity, but it's not the only factor because there's lots of caveats behind this. There's color gains, there's artifact from the struts of the valve. There's lots of things up that you could look at it. So this is one of the things that so here you're thinking, oh, maybe it's more than mild because it looks a little bit, and as well, you can have eccentric paravalvular regurg where the actual regurgitant orifice is small, but the jet is angled a little bit. It's not angled directly orthogonal to the plane of the annulus and going directly. It might be, you might be cutting the color up a little bit more, so you have to be kind of careful about that. So, but this is one of the things. So here you're thinking, oh, maybe it's more than mild, maybe mild to moderate, maybe moderate based on this. But we'll talk about the circumferential extent grading in a second. Keep a track of time. So here's the apical 5 color compare. So here's the CW. Here's the apical 3. There's the CW here. So the CW is not a complete envelope. It's possible we're not sampling it correctly. So for me, this is mild, maybe mild to moderate. And then you have the hemodynamic comp. You go look at the pulse wave Doppler and here's the descending aorta. There's not even a hint of holodiastolic flow reversal. So I wouldn't call it moderate. If you want to call it mild to moderate, that's okay. But I think this was reported as mild. Here's the abdominal aorta. So, okay. So the general Doppler parameters for prosthetic aortic valve regurgitation, and this holds true for TAVI valves, bioprosthetic surgical valves, mechanical valves. So the things I would look for in terms of usually normal, possible obstruction or significant obstruction, peak velocities, right? Remember, greater than 4. The jet contour is more triangular early peaking if it's normal. If it's stenotic, usually it's rounded late peaking and usually denser. You can look at correlate that with the acceleration time. There's this parameter called the AT over ET, the acceleration time over ejection time. And as the stenosis becomes more significant, that becomes broader. It's just a reflection of the late peaking nature of the Doppler profile. And then the DVI, the less than 0.25 we know is in the severe range, and normal or not significant or mild is greater than 0.35. There's criteria for TAVI valves, particularly with regards to changes from the baseline imaging. So we always get a baseline pre-discharge, and that's hopefully what you use long term. Sometimes it may not be, depending on the patient's hemodynamic status, for example. But if they're stable, it should be what you look at for changes in the baseline parameters over time. And this is from the 2024 guidelines for evaluation of prosthetic valve function. This is a joint statement by ASC and other societies. So mean aortic valve gradient, less than 10 millimeter mercury change from baseline is normal, 10 to 19 is possible stenosis increase, and greater than 20 is significant. And these are changes for DVI and EOA. So if the effective orifice area, the reduction is less than 0.3 centimeters per second or 25% baseline, is kind of probably not that significant, and then significant if it's significant change of 0.6 square centimeters or more than 50% from baseline. Okay, so just as we assess the hemodynamics of the aortic valve, the TAVI valve, the guidelines suggest the measurement for the LVOT should be outer to outer at the ventricular aspect of the TAVI valve, mid-systole, and you want to be consistent. So, Bob Howard will tell you, you shouldn't expect the LVOT to be changing from study to study. And it does change from study to study. So, but just be aware. You want to place the pulse wave sample volume immediately proximal to the ventricular edge of the stent before that area of flow acceleration. And as you know, sampling, if you sample within the stent, within that flow acceleration, you'll falsely increase the LVOT, VTI, DVI, and the EOA. And similarly, if you go too ventricular, then you're going to underestimate all of these parameters, underestimate the stroke volume, the EOA will come out to be low, etc. So the placement becomes quite important. Okay. All right. So second case. What kind of valve is this? Because the imaging is not quite as good. Maybe it wasn't Phoebe. Yeah, this is a sapien. Yeah. So pretty short. So can you see the cusps well? No. What about colored Doppler? Anything worrisome here? Nothing significant. You actually don't see much flow acceleration. Having said that, we're not parallel to flow, right? We're perpendicular to flow, so we may underestimate. I don't see any regurgitation. Short axis. Similarly, not much flow acceleration on this view. Don't see any regurgitation. Having said that, the image quality is not. There's some challenges, right? So here's a sweep. Coming down at the LVOT. Nothing significant, right? 5-chamber, what about this? Now we're parallel to flow, right? So now you see that flow convergence, that flow acceleration, that aliasing, right? The velocities, once they exceed this 60 centimeters per second, this 6 centimeters per second turns from blue here into yellow as the velocities exceed that, and it aliases. You get that flow convergence. Once again, you don't see any regurgitation. So here's the CW. So this is at baseline, and this is after this bit of contrast enhancement. And actually, the gradients are about the same. So here you're getting 36, 39. Over here, a little bit higher, 43, 40, 41. But it's a much better Doppler envelope. Just remember, if you're using contrast to enhance, so it has to be a very low concentration of contrast, and you have to turn the Doppler gains down because the blooming artifact will cause overestimation of the gradients. You want to really guard against that. So this is a pretty high gradient across the valve. So what's the cause of this, right? There's some process going on that is causing the valve to be stenotic. This is clearly stenotic. In order to let's see what I can't remember what it is. Okay, so here it is. So these are some of the things you have to think about. So if it's high gradient at baseline, so this is like same day TAVI or the next day, then obviously these things you have to think about. So is it patient prosthesis mismatch? Is the valve too small for the patient? Is it the small valve because of a small LVOT? That kind of goes to patient prosthesis mismatch. And a lot we do valve in valve as well. And as you know, when you do valve in valve, you're gonna have some degree of mismatch. Has there been under expansion of the valve? Are we dealing with a high flow state? Is the patient anemic postoperatively and the gradients are high? But that you should compensate from that with the stroke volume. Is it a pulse wave sampling volume error? Is it discordance? Is it pressure recovery? The aortic root very small and you overestimating the gradient because of pressure recovery? Or is the obstruction not at the valvular level, but at the supravalvular or the subvalvular level? If it's new or progressive, so the gradient was fine early on, now they're coming back and it's late, then is it thrombosis or this halt, hypoattenuated leaflet thickening, which is subclinical thrombosis of the valve? Is there structural valve deterioration, calcification over time? Is it a vegetation or endocarditis? Is there frame deformation? Is there panis formation late? Is there new high output physiology? So the patient has developed this, let's say, developed an AVM, or they become anemic or thyrotoxic, for example, or is it differences in measurement or loading conditions? So the patient went to have a TE to investigate. And so what do we see here? Yeah, so the leaflets do a little bit, are thickened, more than I would expect. I can't remember how old the valve was. What else do you see? Let's look over here. What's this? What's that? Not every bead. There's something prolapsing into the ventricle. Yeah.
Yeah, although in the aortic valve, there's like, you know, the pressure before the valve and after the valve are not that different in terms of pressure, unlike the mitral valve. On the mitral valve, you have a low pressure side, which is the left atrium. So in the aortic valve, it could be on both sides or either side.
Are you talking about infective endocarditis?
Yeah, infective endocarditis.
Yeah, although it's still
about low pressure.
Yeah, although it's still more likely on the ventricle aspect. It's still, we do see vegetations on the aortic aspect, but they're more likely to be on the ventricle aspect. Yeah, so it's a mobile echo density prolapsing into the LVOT. So the differential diagnosis for this obviously is infection endocarditis, thrombus. Probably not a valvular tumor. I don't think I've ever seen a valve. I don't know if you get a valvular tumor on a prosthetic valve. Probably not, right?
No.
So, all right. So turns out this was valve thrombosis. Yeah, cultures were negative. It wasn't compatible with. So here's the flow acceleration here. No regurgitation. Yeah. So here we're at the cusp level here on the short axis. Here we're a little bit below, and you can see the mass in diastole, and that's a thrombus. Anyways, the patient was admitted, got IV heparin, placed on a apixaban for several months, and came back. And here's the TE late after. It's just the leaflets are still a little bit thickening. There probably is a degree of halt, but that mobile echo density on the LVT aspect has now disappeared after several months of apixaban. It might have been a month and a half. So still some flow acceleration. I can't remember the gradient. The gradient was definitely better. It might have been completely normal, but so it's short axis.
So what are some of the risk factors in a prosthetic valve having thrombus? Do they have often other things that goes on?
Yeah, you always wonder if there's a hypercoagulable state, for example, and we do see that in some patients, but a lot of patients there's nothing.
Yeah.
It's so goes back to this phenomenon, halt. Hypoattenuated leaflet thickening. And this is from a review paper in JACC 2 years ago. And there's different grades of halt. So this is one of the cusps of the valve, a schematic diagram. Here's grade 1, grade 2, grade 3, just different degrees of thickening and involvement of the cusp. So less than a quarter of the cusp involvement is grade 1, and then more than 3/4 is grade 4. And this grading is mainly by CT. So we don't have the spatial resolution by echo to tell. So, and this is the short axis imaging here. So CT is really the best. Seen best on cardiac CT. Thought to represent thrombus deposited on one or more of the cusps. It can cause elevated gradients, sometimes not. Sometimes it can be an incidental finding. You can suspect it on TT if the gradients have gone up, but you need CT to fully define it. You might be able to see some of it on T if it's a good quality T, but CT is definitely better for looking at it. And this is thought to be as high as, in some studies, as high as 30%. That's probably if you routinely do gated cardiac CT on every single TAVI patient, you might find it up to a third of patients, but many of these cases won't be hemodynamically significant.
So I guess this begs the question of drug therapy, so these patients are not on anticoagulants.
Yeah. Yeah.
I'm not sure.
They're probably on some antiplatelet therapy.
On antiplatelets,
Yeah.
but not anticoagulants, and when maybe you're gonna mention this, but what percentage of patients who get halt, who get anticoagulated, actually resolve.
Yeah, I don't know the exact percentage, but a
Because I
number.
think that's what we're trying to do.
Yeah, a number of them do get better, but I don't know. I don't think it's 100%. And I'm not as familiar with the literature, but there are clinical trials, obviously, that have looked to study this. And we do see them. We do see patients who. So it's not routine that they're on anticoagulants and they're using more DOACs as opposed to warfarin. But I don't. I need to just follow them. But you're right. There probably are times where, depending on how early you catch it, it may be more amenable to systemic anticoagulation. Sometimes if it's years down the road, then maybe not. Then it becomes kind of more, not kind of more chronic, I guess. Um, so we talked a bit about this for regurgitation, the number and location of the jets. Is it transvalvular, paravalvular? Can you get a vena contracta, circumferential stent, jet width, the LVOT with the classic kind of AI parameters, which doesn't work quite as well for paravalvular as opposed to intravalvular. You want to look at the density and the slope, that pressure half time on continuous wave Doppler, and then the diastolic flow reversal in the descending and abdominal aorta. So the circumferential extent is useful, but should not be used alone, particularly when you have multiple discontinuous jets. And color Doppler, the spatial resolution is not great. So sometimes you can have two small jets together, but they look like they're contiguous. Especially on transthoracic. T is probably better because the spatial resolution is definitely better. But once you put color Doppler on, your spatial resolution gets less, and your temporal resolution definitely gets less. But as a conventional guide, if it's more than 30, if it's up to 30% or a third of the circumference of the annulus, then you have to think that it's severe. And then it becomes a bit subjective because sometimes we'll see two or three jets, and then we're trying to add them all up together, and so that's when you have to look at that's when things like the diastolic flow reversal, is the stroke volume increased, but this gives you kind of more of a holistic look at the hemodynamic aspects of aortic regurgitation. So, over the years, we know that aortic regurgitation is really important post TAVI because it has prognostic implications, and we knew that early on. And before we use CT to guide sizing of the valve and guide the do the procedural guidance, and when we're relying on TE to look at size of the annulus to size the aortic valve, etc., the severity of the incidence of paravalvular regurgitation was higher. Now it's less actually. So the stenographers know we don't see it that often, and many times we don't see any regurgitation whatsoever. And if it is, it's trace or mild. The majority. I can't remember the last time I saw severe paravalvular regurg from a TAVI valve, even moderate. So this is a pooled analysis of 38 studies, greater than 25,000 patients. And when you look at in red, no or trace versus mild in green versus moderate to severe in this blue, you can see the gradations of outcomes as the paravalvular regurg increases. And even mild PVL versus no PVL has prognostic implications, both in terms of overall survival, freedom from rehospitalization, and freedom from cardiovascular mortality. So it is important. So one of the reasons why we really try and look at it and report it as much as possible. So this is from the 2024 guidelines for evaluation of prosthetic valves. Very similar to what we do for native valves as well. So mild, moderate, severe. You look at the various structural parameters like LV size, the qualitative and semi-quantitative Doppler parameters like the width, the vena contracta, circumferential extent we talked about up to 30% is severe. Is the jet density, is it incomplete or faint versus dense? Pressure half time, is it very steep, less than 200 is the cutoff that will be used in general for severe. Whoops. And diastolic flow reversal in the descending aorta, abdominal aorta. If you can quantify it, which I don't think we have good tools to look at regurgitant volume, regurgitant fraction by echo with paravalvular regurgitation. It's probably a little bit better with intravalvular, but even intravalvular aortic regurgitation is a bit challenging. It's much better for mitral and tricuspid regurgitation. Okay, so a couple of caveats. So that should be an I there. My apologies. AI pressure half time below 200 milliseconds on a whole diastolic flow reversal supports severe regurgitation, but just remember it can be influenced by things like LV compliance, vascular compliance, aortic compliance, for example, and acute loading conditions. Eccentric wall hugging PVLs may look small, and conversely, you can have a small jet in the apical 5 and apical 3 chamber view that leads to entrainment. It looks like a big jet once it hits the LVOT, but you really have to look at that proximal segment. And if the echo parameters disagree, then T can help better define mechanism, location, maybe severity, and then CMR is useful for looking at total regurgitant volume and fraction because they have a holistic approach of being able to look at that without necessarily looking at the regurgitant jet. Okay, all right. So probably a balloon expandable. I suspect it's a sapien. Regurgitation? Paravalvular or intravalvular? So you close your eyes, you think that's probably paravalvular. It's anterolocated. It's kind of headed down, interestingly enough. It's headed posteriorly. So you think, oh, yeah, it's probably paravalvular, right? So this was the case where you couldn't tell on the short axis. So because you can't see it, right? The systolic flow, you don't see diastolic flow. So
High,
yeah.
a little too, on the valve, need to be below.
Yeah, although you can't see the cusp, so you're not sure exactly where it is. So here's the 5-chamber zoom view. It's intra, right? It's intravalvular and it's directed anteriorly. And what we saw on the parasternal long axis is the distal jet bouncing off the anterior aspect of the LVT and going. So this is intravalvular. And confirmed on the apical 3-chamber view. So, and ideally what the sonographer should have done was to go back to the short axis again and do the sweep. Because this is the clue. And we do see that often. You don't see it on the short axis, then you see a little jet on the apical views, and it's like the light bulb goes on. And then at the other side, they'll go back on the parasternal and then try and find it. Because you really want to correlate, because one of the elements of parameters, as Bob Howard mentioned, is that circumferential extent. You can't tell circumferential extent from the 5 and the 3-chamber view. You can have an idea, but you need that short axis view to be able to tell the circumferential extent. Okay, so here's pretty complete. The pressure half time here was 463 milliseconds. It's relatively dense, not quite as dense as the forward flow. So we called it moderate. This is moderate intravalvular prosthetic regurgitation. Oh, and descending thoracic aorta. So no whole diastolic flow reversal. The cutoff we use, remember, is 20 centimeters per second. Doesn't even get close to that. And then, oh, I didn't do the abdominal, but there wasn't anything on the abdominal. Okay, here's another case.
So before you go, was
Sure.
this an old one or like, this wasn't an acute valve?
No, there was another one.
So I guess the suspicion
Is
for
valve.
intravalvular, if it's 5 years old.
That's true.
I mean, if it's just put in yesterday, would be surprised to see this.
Yeah, I guess if you look at progression over time, when you look at structural valve deterioration, you're more likely to get intravalvular versus paravalvular. But it's sometimes you get worsening paravalvular as well. But you're right. Then it becomes kind of like a bioprosthetic aortic valve, right? So okay, so mindful of time. So here's another case 4. Okay, image quality is a little challenging. So regurgitation? Yes. So this one's a bit more posterior. There's a little anterior jet here as well. It's not as prominent. You see this little blue color here. So here's short axis, and we're seeing it. So we're seeing one here. This is the one that's kind of more anterolateral. This one's kind of more posterior here. And maybe we weren't catching the full jet because remember on the long axis plane, we're cutting through here. So we're catching this component here, probably the tail end of this component here. So it's like 2 separate jets. Once again, the spatial resolution is not great. You wonder, is it continuous? But there may be a gap here. So it looks, to my eye at least, it looks like 2 separate jets. And then once again, hemodynamics sense this. Maybe it's not really quite holodiastolic. That's the descending thoracic aorta. Here's the abdominal aorta, which didn't have. I like to look at it with color Doppler and with spectral Doppler because the color Doppler is also kind of helpful if there's color flow reversal as well, right? So looking for that bit of that red flow. There's a tiny bit of red flow over here, but it's mostly blue, obviously, in systole, a tiny bit of red fluid diastole. So you can see here. So I think this was called mild to moderate, maybe moderate at the very most. So
Is it worth tracing the BTI and the proximal descending?
yeah, we used to do it.
For the diastolic
Yeah,
aspect of
we used to do it, but I I've moved away. Probably because just changing the gains and the wall filters, sometimes you're tracing noise. Now, if it's and as well, if it's super clear and it's clearly holding, you could trace it, but you know the VTI is going to be high, right? So you already have that information. So I just don't think the resolution is good enough for us to have a good VTI tracing, is my opinion. And when it is good enough to have a good VTI tracing, it's probably significant anyways. So you can, it's kind of, you can do it to confirm, but I don't think we have a lot of evidence. Like we used to use a VTI of 12 in the descending thoracic and 6 in the abdominal for severe. But what if it's 5.9? So
our former acolyte director preceding you loved that trying to
yeah,
what he taught me.
yeah, no, and I remember that as well. I just wish we had more data to support that. So
far, nobody has really reproduced those data to support. Yeah,
I think this is the last. I think this is the last case. Okay, so sorry, there's a bright reflection there. I thought I'll look at this way here. So this is post TAVI. What do you think about this one?
Early or late post.
This is early. I'll show you some more. We can come back. Any regurgitation? No. He has an apical 5 on the left, apical 3 on the right. Anything out of the ordinary? What do you think? What do you think? Do you think he counts on? So here's color, low convergence. Mean grade is 45. The heck is going on here? Okay, let's go back. Now you're really intrigued, right? So what's going on here? The image quality was better, like obviously patient factors, etc. You can only have so much to work with. You'd be able to tell this more. Is there anything unusual about the valve?
It's low.
It looks low, right? So this is the valve here, and these are the native cusps. Yeah. So the valve slipped into the LVOT. So you're picking up the native aortic valve stenosis, which obviously was severe before. So, and if you can look here, so again, sorry, it's a little bit, it's a kind of bright here, but the valve is sitting in the LVOT, and that's the native cusps over here, which is restrictive and calcified. Yeah. So kind of slipped into that LVOT. Anyways, the patient went on to have a bioprosthetic aortic surgical, had a SAVR after. So this is after this. So they had must have been a Carpentier. So this is a bioprosthetic valve. You can see the three struts of the valve with the short axis. That's the hallmark of a bioprosthetic valve. Okay, so I focus a lot on the valve. Obviously, the echo has to be complete. So we do other things as well. So this is just an example of improvement of mitral regurgitation post-TAVI. So it's moderate MR before. See the flow convergence here. And this is after. You can see it's gone down to trace. So that's the hemodynamic aspects. So you've resolved that pressure overload of the left ventricle. And what's this? Here's another post-TAVI phenomenon. What's this? Pardon me? Yeah, so this is mitral leaflet SAM and LVOT obstruction post-TAVI, which you can get post-surgical AVR as well. So you relieve that high afterload, ventricular function improves, becomes hyperdynamic. The ventricle is already hypertrophied and small because of the severe calcific aortic valve stenosis long term. And you get SAM and LVOT obstruction. Peak graded here is like 5. The gradient was higher down through the LVOT than it was before the valve was put in.
Is that what they call the suicide ventricle?
I'm not sure what the definition of
I think the intervention is calling that, like when the heart like really, really strong and then causing its own obstruction.
Yeah, I think that's a very negative connotation, in all honesty. But
That's the term I heard.
okay, so We do have a bit of time for questions. So just remember the major questions: is it well positioned? Is it functioning normally? Is there regurgitation? Where is it coming from? What's the severity? Is there good ventricular and hemodynamic response? Is there any early complications? Okay, thank you.